Welcome to our quarterly virtual education event for Rocky Mountain Cancer Centers. I'm Dr. Mabel Mardones, a medical oncologist who specializes in breast cancer. I'll be moderating our program today, talking with 5 of our partners about updates in breast cancer that will help you optimally care for patients who may be newly diagnosed or have a history of breast cancer. With me today are Dr. Ling, medical oncologist from our Lakewood Clinic, Dr. Archuleta from our Pueblo Clinic, Dr. Gerlinde Tynan, our breast surgeon in our Longmont Clinic, Dr. Charles Leonard, our radiation oncologist with Rocky Mountain Cancer Centers, and Dr. Manoj Bupathi, our medical oncologist from our Aurora, Englewood, and Littleton clinics. Before we get started, a few items of note. Attendings will be muted throughout the presentation. However, we hope you will be involved in entering questions into our chat feature. We will be monitoring the chat throughout the presentation. For those of you who carry COPIC, your attendance today will be reported directly to them and you will earn ERS points. If you're joining as a group, please email a list of participants to the following address. The email will be put in the chat box now. Thank you for taking the time to join us. The 6 of us have worked together to come up with topics we thought would be of most interest to you. Today, we will be discussing screening guidelines, identification of high-risk patients, surgical staging of breast cancer patients, differences between radiotherapy breast cancer regimens, and breast cancer survivorship. The first topic today will be with Dr. Ling, and the following is our question for today. Is 3D mammography the new standard of care? And is it indicated for everyone? And what are the pros and cons compared to a regular 2D mammography? Thank you for joining us, Dr. Ma.
Thank you, Dr. Mardones, and hello, everybody. I hope you can hear me well. So we all know the problem with mammography is that a small cancer can be hidden by the breast tissue overlying or underlying it. So during a 3D exam, which is a very more advanced technology than the regular 2D mammogram, during the 3D exam, an X-ray sweeps in a slight arc over the breast tissue, taking multiple low-dose X-ray images. And then a computer can produce a synthetic images of the breast tissue, a 3D image. So the images includes very thin slices, like a millimeter slices. So it can provide more detail than the old 2D mammogram. So it reduces the overlap of the breast tissue, make it possible for a radiologist to better see through the breast tissue on a 3D mammogram. So it is definitely a more advanced technology, and it is considered a new standard. And I would say it applies to everyone who would benefit from a regular 2D mammogram, especially in women who have dense breast tissues. So according to the study, compared to a regular 2D mammogram, 3D mammogram gives higher detection rate, increase about 25%, and lower recall rate and lower false positive, obviously, by about 15%. So people would have fewer unnecessary biopsies. So those are all the pros. Unfortunately, we don't have survival data at this time or mortality data. That means, does 3D mammogram give us more survival compared to a 2D mammogram? But we all know it takes a long time to get survival data. But because of all these proofs, it has become a new standard of care. So people have a couple of concerns. I would say that those are cons, but not severe, not significant. One is the cost. So obviously it's more expensive than the regular 2D exam, but Medicare and most of the private payers now have been paying for it. And I actually, before this presentation, I checked around our local radiology facility, they conquered this. So when you order a mammogram, a lot of facilities now default to a 3D mammogram. Some of them still require you to order as a 3D mammogram with tomosynthesis. Some don't even require that order. You can just order the mammogram, patient will automatically get a 3D mammogram as long as insurance cooperate. So the other, I think, concern some people may have is slightly higher radiation exposure compared to a regular mammogram. But even in the 3D, the radiation exposure is still relatively safe, very safe actually. If you compare to the annual natural background radiation dose, it's only a fraction of it. When I did the math, I think it's about 20%. But more recently, there's some new softwares allows the people to do synthetic images, and that decreased the radiation exposure to even similar to the regular 2D mammogram. So I think that's a really good, another technology advance. So I would say I would recommend 3D mammogram for any women or who would qualify for a 2D mammogram. According to the study, actually, the first screening mammogram patient gets most benefit from 3D mammogram because we don't have a baseline to compare to. So give you definitely less false positives. That's my answer.
That's wonderful. Thank you, Dr. Ma. Very, very informative in respect to very, very important outcomes, which is less callbacks, less anxiety, and improved accuracy and detection, which obviously, as we all know, makes a tremendous difference. And I completely agree with you. And we're fortunate, obviously, in the state of Colorado to really have pretty successful coverage, as you said, in respect to 3D mammography. Thank you so much. We'll move on to our second topic of today, which is Dr. Travis Archuleta. The question to you, Dr. Archuleta, is who may be appropriate patients to be seen in our high-risk breast cancer clinics?
Sure. So we do have these high-risk breast cancer clinics, and as we know, breast cancer is one of the more common cancers we deal with. The average risk for any person is around 11 or 12%. For our high-risk clinics, we're looking at people who are at higher risk than that. So one of the ways we can assess lifetime cancer risk is using various screening models. One of the most common we use is called the Gale model, the Gale risk model. It takes into account age, age at menarche, age at first live birth, and whether or not you have any first-degree relatives or previous biopsies or any atypia on your biopsies. It probably underestimates the significance of family history outside of first-degree relatives, but it's a fairly easy model to use, easily available on the internet. So patients who we use these various risk models, if they come out with a score greater than 20% lifetime risk of breast cancer, we'd like to see those patients in our high-risk breast cancer clinic. Also, any patients who have first-degree relatives with breast cancers are at considerably higher risk, and we'd like to follow up with them as well. Another factor that we look at is abnormal biopsies, especially lobular carcinoma in situ. That's a extremely high risk finding, increases your risk around 10 times. So those patients we'd also like to follow closely in our clinic. Speaking of family history, it's not only breast cancers we worry about, we also worry about ovarian cancer history, pancreatic history, and prostate cancer history. All of those connote an increased risk of breast cancer in patients. And of course, any patients who have any specific concerns other than those, we're happy to see in our high-risk clinics. One final factor, kind of rare these days as we don't do as much mantle radiation to the chest, but any thoracic radiation given to patients between age 10 and age 30 connotes a very high risk of breast cancer in the future, and they need close follow-up as well.
Yep. Yeah, absolutely. Thank you so much for that summary of these, and all of our clinics take care of high-risk patients. So again, to emphasize, you don't have to have a breast cancer diagnosis for these patients to have a good plan designed in place for not only screening discussions in respect to not only mammography, but the integration of MRI, but also lifestyle, which we all really believe strongly that it is a way to mitigate cancer risk in general. Thank you so much, Dr. Archuleta. Let's move on to our third topic today, which is with our breast surgeon, Dr. Gerlinde Tynan. Our question is, as an oncology community, we're trying to find ways to minimize morbidity and short-term and long-term complications for our patients. Right sizing care is extremely important. Along these lines, as a breast surgeon, what are you incorporating into the care of early stage breast cancer, in particular when staging the axilla, to help with this aspect in care of our patients?
Great. Thanks, Dr. Margolis, for the introduction. Yeah, that's a great question. I think one of the exciting things about breast surgery is that we are changing what we do all the time based on data. So, for instance, for breast surgery, we follow NCCN guidelines, so National Comprehensive Cancer Network guidelines, and the goal of the NCCN as well as the oncology community is, like you said, to right-size care and to decrease the risks of future morbidity from the treatments that we give. And I think surgical axillary staging is an excellent example of this. Not that long ago, I would say, 8-9 years ago, anybody who had the slightest bit of cancer in a lymph node underwent a full axillary dissection. I remember taking patients to the operating room. We would do a sentinel lymph node biopsy. We would do a frozen section, and any cancer, boom, that patient got a full axillary dissection with, of course, all of the comorbidities associated with that. There's a real terror in patients out there who have heard of lymphedema, and everyone fears, of course, that they're going to get that. Over time, we've gotten less aggressive. So we went from, any sentinel node positive got an axe dissection to, only in certain cases if there were nodes positive, to now our most recent guidelines just released in May of this year. Even women who go into surgery with a small amount of positive nodes or suspicious nodes can still be offered a sentinel lymph node biopsy. And even with a positive or 2 positive lymph nodes, potentially do not need more surgery. In our cases of women who are undergoing lumpectomy, who are going to have radiation, we don't have to take out more lymph nodes most of the time. The axilla can be radiated. We know that the incidence of lymphedema is about half after axillary radiation versus after an axillary dissection. That's very important. Even some of our patients with mastectomy who undergo a sentinel node biopsy, if they have minimal disease, don't necessarily need to have more nodes removed. So that's very big in my world, really. Other things that we do, we're a little more selective in who we necessarily offer lymph node surgery to. And so in our elderly patients, it's really a conversation. My 84-year-old who has breast cancer, low grade, not aggressive, does she really need to have the lymph nodes looked at? And so that's a discussion I have with patients. I don't certainly think that we have to automatically omit care depending on age, but after discussion, sometimes it makes sense for those patients to say, you know what, the chance of something being in my lymph nodes is small. There are risk models that we can run to kind of get an idea of what the risk of involvement of the nodes is, and they can make an informed decision. We're also, I think, more proactive upfront with preventing long-term morbidity associated with surgery, especially on the lymph nodes. Established breast programs have physical therapists that we work very closely with. For instance, all of my patients who are going to have any kind of lymph node surgery see physical therapy ahead of time. They get baseline measurements, range of motion, etc. We also have newer technology in the form of a device called the SOZO device, which can detect lymphedema before it's even detectable by traditional methods that physical therapists use. We can detect a change in the volume of the arm by about 2 tablespoons. And so we will do a preoperative measurement and then follow them postoperatively quite closely for the first few years, and then less after that. That way, if lymphedema does occur, and typically that's when it's in the first 3 years, then we catch it when it's still reversible. In general, I would say that our goals are to tailor our treatments really to the specific disease that a specific patient has. I always tell my patients, your breast cancer is not like maybe your neighbor's breast cancer, and the treatment that she had is not going to be the same as what you had, especially if you look at the time frame of when those treatments were done.
That's excellent. Thank you so much. I think this is such an important topic that I think has become very clear with our major oncologic societies, as you mentioned. Really trying to do less harm for our patients is really an important endpoint. I believe we are ahead of schedule, Dr. Tynan, and I did want to piggyback on the previous topic, which was high-risk patients. I know that you probably, I want to make highlight to our primary care physician partners here, that you also probably see patients who have never encountered a breast cancer diagnosis, but two are high risk for the many reasons previously discussed by Dr. Archuleta. Could you speak a bit in respect to which of those patients you may be seeing, and how do you approach the care of those patients?
Yeah, I have quite an interest in actually in high-risk patients, and we do a high-risk clinic. Dr. Archuleta mentioned the Gale model, which I think is very helpful. I tend to use the Tyran model a little bit more, just to incorporate, family history better, and I just find it a little more helpful for my clinics. One of the advantages of that model is, again, looking at the latest NCCN guidelines. They actually incorporate that model as regards being able to offer patients breast MRIs and endocrine therapy, right. Which, let's face it, insurance is always kind of a battle, right, that we have to fight. And so having those guidelines that helps put a little bit of clout behind our diagnoses, and having numbers to say this patient is at high risk because they score, 32% lifetime or a 10% 10-year, helps a lot. So obviously our genetic carriers, they tend to lean more towards the surgery side of things, which I think is appropriate. Our other high-risk patients who maybe don't have a genetic mutation, but that have, family history or previous abnormal biopsy or extremely dense breasts, or, tend to have a combination of those things, we offer every 6-month imaging. So MRI, and then 6 months later mammogram, and then 6 months later MRI. So kind of get the idea. So it's imaging twice a month. You really get a better look at that breast tissue. Endocrine therapy, I think, has come a long way. We're with, our team here, we're doing a lot of reduced dose tamoxifen. So that 5 milligram dose for 3 years, based on some studies that showed that that's extremely effective in reducing risk, as effective as a 20 milligram dose. But with minimal side effects. They compared the 5 milligram dose group to a placebo group, and essentially they had the same amount of side effects and the same morbidities. So in other words, the same as nothing. That's very, very exciting. And especially in our atypia patients, the risk is reduced significantly, as high as 68%. And that 5 milligram dose is very easily tolerated. So if we could put in the drinking water, that'd be great, but we're not quite there yet.
Yeah, exactly. I think in general, there's been sort of a lack of uptake of chemoprevention for concerns that these young women tend to be young, and they're in the prime of their premenopausal experience, if you will. And it's a concern, a legitimate concern to willingly take an option that could cause these issues. But low dose tamoxifen, just as you said, is right on with some of the advances that we're speaking about today. With that, let's move on to our fourth topic. Thank you so much, Gerlinde.
Thank you.
So our next topic is in respect to radiotherapy, and Dr. Charles Leonard is joining us today. The question is twofold. I'll ask both of it right away because I think there's going to be a lot of migration between the two. And what are the differences then between radiotherapy treatment regimens? And other than the time commitments that you'll allude to, what are the differences in respect to toxicity and risk to the patient?
Thanks, Dr. Mardones. Hello to everybody. So radiotherapy has really evolved quite a bit since I started doing this 31 years ago. It's evolved from a one-size-fits all to quite a bit of I don't want to say de-escalation, but trying to make things easier on the patient, and in some aspects, de-escalation. As far as the different regimens are concerned, they depend upon the actual clinical situation. And so I want to start with different categories. So we'll start talking about the intact breast, so patients who've had a lumpectomy. patients who've had a mastectomy. And so let's start with the intact breast, or patients who've had a lumpectomy. The treatment regimen has evolved from the typical sort of historical 5 to 6 week treatment every day to now where, depending upon the clinical and pathologic situation and also discussion with the patient, we're able to either treat part of the breast or treat the entire breast. And with partial breast radiation therapy, we're able to make the treatment less cumbersome for the patient. For instance, there are different treatment regimens where patients can finish with twice daily treatments, Monday through Friday, and they're done in 5 treatments. Partial breast radiation therapy can also be given once every other day for 5 treatments as well. And also, it can be given for once a day, 15 treatments. So there are a variety of different treatment regimens that can be used for partial breast, or what we call accelerated partial breast radiation therapy. As far as whole breast radiation therapy, as I mentioned before, depending upon the clinical situation, we aren't able to deliver partial breast radiation therapy. And even that has really decreased as far as the number of treatments. Patients can be treated over 15 treatments now. That's very well accepted. Mind you now, a lot of this depends upon the clinical situation. You have to take things into consideration, such as the size of the primary tumor, lymph node positivity. There are a number of things that go and play into this. With patients who've actually had a mastectomy, the options are pretty much the same as they've always been. So patients are typically treated over a 5 to 6 week course once a day and 5 days a week. But there's quite a bit of ongoing clinical research at the moment to see if we can actually shorten that treatment regimen as well. As far as side effects are concerned, when you're looking at partial breast radiation therapy, I'm going to jump back to that. Really, some of the more common things that we're accustomed to seeing as far as side effects vis-a-vis skin irritation, redness, you typically don't see with partial breast radiation therapy, which really sort of follows because you're actually treating a section of the breast more, you're concentrating dose internally more so. So you typically don't have the skin redness, irritation, you don't have as much fatigue as well with partial breast radiotherapy. The incidence of what we had seen some years ago, as far as injury to cardiac tissues or cardiac issues, lung tissue damage. Those were really the driving forces to really try to decrease the field that we use, and partial breast has been found to be very, very, very useful, very safe, and very effective. With chest wall radiation therapy in patients who've had a mastectomy, we tend to see much more as far as skin irritation and redness. And I want to add that actually is called for in quite a bit of, in a number of circumstances, because we've known historically that after mastectomy that recurrences, when they occur, actually a good number of them occur in the skin or in the scar. And so as it stands right now, we really do try to bring the dose up to the skin. So you typically have more skin redness, irritation post-mastectomy wise. And that even gets very complicated when you have patients who've had tissue expanders placed or immediate reconstruction. As far as how much are we going to try to bring the dose to the skin? And here again, that's another area of active concern, of active research, in that there's some evidence to suggest that we really don't have to be as concerned in some circumstances. But those parameters are yet to be worked out exactly. So as it stands right now, post-mastectomy patients, we really do pay attention to actually getting some of the dose or quite a bit of the dose to the skin as well, which results in skin redness and irritation. And this goes along with whole breast radiation therapy, where patients can have skin redness, irritation, and that usually starts toward the end of the treatment, and it resolves when the treatment's completed. Now, in the long term, partial breast radiation therapy, it can result in more tenderness in the breast. It also can result in more, although slight, you have more cosmetic deformities in that the contour, the natural contour of the breast might have a dimple in it. And that's due just to the evolution of the scar tissue beneath the skin. And it could retract a bit more since you're treating partial breast and you're leaving the vast majority of the breast as virgin tissue. So short-term side effects are more evident with your whole breast radiation therapy or your chest wall radiation therapy. Not so much so with partial breast, but there are more concerns of tenderness in the treatment area, as well as a bit of a dent to cosmesis in some aspects.
That's wonderful. I think it really speaks to the whole theme of today's discussion that we really are not recommending, blanket recommendations for our patients, but really trying to understand their specific scenario and making specific recommendations in that respect. Thank you so much. And let's finish off with our fifth topic, which is in respect to survivorship, which is, of course, extremely important. And Dr. Bupathi is here with us today. And the question is, what can be some of the long-term complications that can be incurred in those patients who either received chemotherapy or endocrine therapy for breast cancer? And we have a second question for you, which you'll probably connect the dots as well. And that is, how is it that our primary care physicians can assist in risk modification efforts to decrease complications of these therapies?
Thanks, Dr. Mardones, for this, and thank you all for joining. So this is an important topic. Survivorship really begins at the time of when patients are actually diagnosed with their original or starts when they're at the time of their diagnosis, and kind of goes through the whole range of going through treatment, post-treatment, and then even long-term. In breast cancer, for women at least, the highest number of survivors are for breast cancer. There's a lot of things that are involved in post-treatment follow-up in terms of, what do you look for? How do you look for it? How often do you look for these things? And, one of the things is obviously looking for local regional recurrence of breast cancer in itself, or even contralateral risk of recurrence, whether that be with physical exams, looking for chest wall recurrence, axillary recurrences, with axillary recurrences, mammograms, MRIs, screening tests are also important. Some of the for patients who have received chemotherapy, especially if they're younger, you could get chemotherapy-related leukemias, especially for those that have gotten like topoisomerase inhibitors or even platinum agents. And typically they can happen anywhere from 2 to 5 years after their treatment. And the decline usually happens about 10 years after their diagnosis. And for those that have received radiation at a younger age, especially those that are in like the AYA population, how much they've received, what's their cumulative dose of radiation is really important. Some of the things that they can get are something like ALL, lymphomas, sarcomas, things like that are important. For patients that have received these chest radiotherapy, really important to have their annual mammography, sometimes even thinking about MRIs as well. For patients that have other risk factors, risk modification is really important. For those that are smokers, low-dose CT scans for lung cancer screening is important. And, for the young patients, if they have genetic testing abnormalities or family hereditary risk factors, then colorectal cancer screening if it's appropriate. Those that are on like hormone therapy or anti-estrogen or early menopause, then evaluating with bone density scans, blood work, cholesterol modifications, all those things are important as well. Bone health is really important for these patients as well. Psychological and social well-being, those are some things that sometimes can go by, can kind of be put off just because of everything else that we're dealing with. But sometimes they may be the most important things to address, especially in the younger population. So I think there's a category of involvement in every section of what we do for survivorship for these patients, and part of it depends on are they younger or are they older, but really looking at blood work, other cancers, complications from the cancers that they've received, treatments that they've received, are some of the key things to kind of keep a close eye on.
Thank you, Dr. Bupathi. There's, as evidenced, a tremendous amount of partnership that we can all undertake in the management of breast cancer survivors. And we've had a number of great questions come in through the chat box. And what I'm going to do is direct some of these to our panelists before we conclude. So one of the first questions coming through for us, which I will direct to Dr. Tynan, is how do you recommend that a primary care physician start the conversation about high-risk concerns?
Yeah, that's a great question. I think a lot of patients, you have two categories of patients, it seems. You have those patients that are convinced they're high risk because their grandmother had breast cancer, right? And then you have those patients that, don't even think about any kind of risk for breast cancer. So, family history is an easy way to start the conversation, right? And so if you have your patient who has, mom, grandmother, aunt, sister with breast cancer, obviously they're at higher risk just from that close family relative. But then you can then ask them about, well, have you had biopsies in the past? How old were you when you had your first baby? So we know that women who never have kids or have kids at an older age have increased risk. Early menses are another risk factor. For those women who don't really have a family history, just a little bit of a breast history. Again, have you had any problems with your breast? Have you had any biopsies? And once they start talking about those things, I think then it's easier to kind of ask those other questions that are less obvious to people, but do increase risk. One of the risks that I think people forget about when I give talks, when I mention daily alcohol use, sometimes there's a little gasp in the room and people are like, oh my gosh, I can't have my glass of wine at night. So lifestyle modification, long-term hormone replacement therapy, there's so many different ways that I think you can incorporate risk into those conversations that you're already having with your patients.
Absolutely. That's a great point, particularly in respect to hormone replacement therapy. As we speak to them about how long they should be on them, it might be a nice way to integrate that natural discussion in respect to risk. This is a very interesting question and follow-up. This I'll address to Dr. Ma. And the panel, the question says a bit off topic, but says, what are the current guidelines for delaying routine screening mammography following COVID vaccination? Is it 6 months after the last shot? Question mark.
So that's a common question we've had since last year. We've noticed there's some false positive, especially large lymph nodes on the routine mammograms after COVID vaccination. So I believe most people believe now 4 to 6 weeks after the last shot should be a good time to do those routine screening mammograms. But that only applies to screening mammograms or, the patient has no symptoms. If they have symptoms, I wouldn't wait at all.
Yeah, I agree with you. I don't think that the American Society of Radiation has put out a statement in respect to delaying. I think we are generally recommending people proceed. They will likely go back with an ultrasound potentially to that, that side to re-image 3 months later to be certain. But I agree completely. If any symptoms or high risk, there really should not be a delay. Let's move on to this next question, which is in respect to what are there different recommendations for assessing men for high risk for breast cancer? And I will address this to Dr. Bupathi.
This is actually a relatively tough one.
Right.
male breast cancer in itself is not very common. Certainly, if you're thinking about screening for high-risk cancer, I think part of it comes down to family history, genetic testing, things like that. And if anybody, whether it be male or female, if there's any symptoms, I would certainly pursue imaging and evaluation as to what this could be. I don't know if there is any specific guidelines that say that this is when you would start screening in the absence of a genetic alteration that I'm aware of. I'm going to kind of reach out to a lifeline of my panel here to say if anybody else has any other advice on this.
Yeah, I agree with you, Manoj. I think there is no clear guideline, and I think clinical examination, particularly in men who maybe even have gynecomastia for other reasons, is particularly important. And of course, if we have anyone who's had a germline mutation in BRCA2 in particular, are at a higher risk for breast cancer than the standard male, though still quite low in incidence as compared to women. So I think clinical examination really becomes key in those patients. This is a great question next, and the other one is a comment, but we'll definitely send out a link. They requested a link for the models that we've been speaking about in respect to patients who are at high risk. Namely, we've mentioned the Gale model and the Tyrer-Cuzick version 8, which is the newest model incorporating family history. We will definitely be sending that information to all of you. This next question is pertaining to mammography. Which recommendations do you think, or which guidelines, societies do you think we should follow as primary care physicians for mammography screening? I think they're getting to the point of when should we start screening mammography? Is it 50? Is it 40? Do we listen to the USTPF Society, American Cancer Society, et cetera? And I think I'll probably have any of you who feel comfortable with this question weigh in. We'll start with Dr. Tynan.
Yeah, I mean, the surgical societies, American Society of Breast Surgeons, I mean, we really follow ACR recommendations, which are for yearly mammograms starting at age 40. I'm a realist though, and I have a discussion with my patients. I mean, if a woman who comes in, and she's 50 and she has, fatty breasts on mammogram, no real risk factors, is it okay for her to get a mammogram every other year? Probably, right? I mean, honestly, most women do not fit that category. Okay, and my main concern with those recommendations where they, ask you to do it every 2 years and not start until age 50. The problem is that most women do not know what their risk really is. Okay, because again, grandma had breast cancer. Oh my God, I'm going to get breast cancer. See, that's not accurate. But women who think I have no risk factors for breast cancer don't realize that the fact that they had their first period at age 9, they didn't have a baby till they're age 40, and they have dense breasts, they have significant risk. And so I think that's one of the reasons that ACR, American Society of Breast Surgeons, we still recommend yearly mammogram, because honestly, there are so many patients out there who have an increased risk and don't even realize they're high risk. And those are the patients that are going to get breast cancer in between those 2-year mammograms. That's my personal opinion.
If we have anyone else who'd like to weigh in, that's wonderful. Otherwise, we can move on because we're getting some great questions here today. I do want to stop and say that if we do not get to any of your questions, we will be sending you a personalized response from one of our panelists to your email. So let's move on then. So it sounds like you answered it very well and clearly. So this is a very, very real question in the sense that there are patients who do adamantly refuse mammography. We know that that's the case. And the question is, are there any alternatives that might be helpful? Thermography, ultrasound, etc. So I will have Dr. Archuleta weigh in on this question for us.
Unfortunately, there aren't great alternatives to mammogram. Ultrasound is really not sensitive enough to pick up the breast cancers we need to pick up. Thermography, I'm honestly not too familiar with, but I think really the standard of care is still mammogram. You can do ultrasound and clinical breast exam, but again, you're going to miss a lot of breast cancers that way. I think a lot of the concerns are comfort, and that's understandable, but it's really something that needs to be done. I don't know if my panelists have any other alternatives to mammogram that I'm unaware of, but.
Is there anyone else in our panel who would like to weigh in on alternative modalities there? Hi, Dr. Ma, comments.
Yeah, I agree. I agree with Dr. Archuleta. So mammogram is so important. I would definitely, I believe you probably showed the patient all the data, how much lives mammogram has saved. And ultrasound can pick up things, mammogram can pick up things ultrasound or physical exam cannot pick up at all. So even MRI sometimes cannot pick up some of the things mammogram can pick up. So it's definitely a suboptimal care if we don't do mammogram. So as long as we have that discussion, I mean, we can do the best for the patient. Thermography is not a standard care. I don't think I'm comfortable with that either.
Yeah, I would agree. And in particular, mammography is complementary in the sense that we would be able to detect calcifications, which as we know, there are many reasons for benign calcifications, but namely that's one of the first signs on mammography for DCIS, which is considered stage 0, extremely curable, treatable disease. And so again, early detection does make a difference from that standpoint. So really should not be exchanged for anything as equal as such. Again, our chat box is lighting up here with questions. I'm going to go down on that question there, farther down. And do you still recommend clinical breast exams for yearly physicals or a self-breast examination? I think do you still recommend, clinical exam basically. Is this still something that our OBGYNs, our primary cares should be doing? And let's go with, let's see here, most of us have answered. Let's go to Dr. Bupathi.
So I would still say clinical breast exams as well as self-breast exams. I talk to patients about doing both of them, especially with survivors, making sure that they do all the above. I think sometimes things can be palpated when they're not in the office and such. So I recommend breast exams, self-breast exams, and imaging.
Okay. And we're getting on the same vein some more questions about screening modalities. Is it ever worth doing an ultrasound along with a mammography, 3D mammography? And let's have Dr. Ma answer this question.
There's definitely some indication for ultrasound combined or MRI combined with mammography. I didn't go into more details, but when I was reading on the 3D mammogram, there was a study showing that, which patient population benefit from 3D compared to the regular 2D mammography. As I said, the most people between 40 and 75 in that study, the first screening mammogram is the biggest benefit because you don't have a baseline to compare to. For the later years, people who have dense breast tissue, benefit more. But interestingly, for a patient who has extremely dense breast tissue, 3D mammogram did not offer more benefit than 2D mammogram. For those patients, definitely another modality like ultrasound or MRI will definitely add on, in addition to the regular mammogram or even 3D mammogram. And as Dr. Archuleta said, for the high-risk patient who have lifetime risk more than 20% or other reasons, we also need to add ultrasound or MRI yearly, in addition to 3D mammogram. Actually, that's what the NCCN guideline is recommending right now too.
Perfect. And again, these are many of the topics that we would be discussing if you feel, as our primary partners feel, that these patients need to be seen in our clinics, these are many of the questions that we address and intentionally develop a plan that makes sense to each individual patient thereafter. And with that, I'd like to thank all of our experts for your comments, your expert opinion. Thank you to the participants for joining our event today. We welcome your feedback. Have a great rest of your day.